This is the West Group. My name is Brian Morales, and I have a few administrative announcements to get ourselves started. First, I want to discuss civil society engagement. In the July 2023 launch of the coalition, there was a ministerial declaration that was agreed on to accelerate and strengthen global response to synthetic drugs. And at that meeting, participating governments expressed their commitment to take into account input from civil society in coalition objectives. When we started these sub-working group meetings, the decision by consensus was that this should be a closed forum for governments and for international organizations. So we've been working to develop a plan for civil society engagement. And that plan will be posted on the website in the coming weeks, globalcoalition.us. But for now, I wanted to outline 5 areas of engagement that will comprise this civil society engagement. First, we are going to establish national dialogues for coalition governments to engage their civil societies. The U.S., leading by example, will host a civil society roundtable for U.S. NGOs on January 27th, and will encourage other countries to do the same. If you do, please provide a report, a summary that we will be posting on the website to document that meeting. Additionally, we will be supporting and looking for the Vienna NGO Committee to host a global civil society forum, which will include global voices of civil society through their networks, also at the end of January. Between the months of January to April, we're looking for civil society organizations to share with us their videos, their recordings of experiences, of initiatives that they've undertaken, and we'll be posting those documents, those videos on the coalition website as well in a space dedicated to civil society. And then we'll also be inviting recommendations to also be posted on the coalition website from CSOs. Finally, between April and July, we'll be welcoming civil society organizations to share their achievements that they have made, and also welcoming, again, mixed media, recording, videos, and documents that we can also post on the website to share those achievements of what has been accomplished. And then also at the discretion of co-chairs, if they would like to invite civil society representatives to present or participate in specific sub-working group meetings, we can also look for those opportunities from April onward for there to be special meetings with unique links for them to participate in some special topics. Now, my final slide is to share with you that we have a website for the Global Coalition. It is globalcoalition.us. Specifically under the sub-working group section of that website, you will see that we have the upcoming agendas. So you could see in real time what the plans are for the upcoming month, what topics will be covered. You will also be able to see past recordings if you've missed any sessions. And we also invite you to submit videos for the website. So if you have any specific topics that you would like to present on, there's no limit in terms of how long the presentations can be. So you can take your time and provide a little bit more depth into that work. So we also invite you to submit both videos as well as documents or other content that we can also post on the website. So that is it for me for today. I am going to turn it over now to our co-chairs, Benoit Archambault and Charles Perry, to lead today's session. Thank you all so much.
Thanks a lot, Brian. Hi, everyone. Good morning from Montreal. A snowy day. Good evening.
And Benoit, my apologies for interrupting. You need to be in the English channel, please. If you can click the icon of the globe and select the English channel, and also speak much closer to the microphone. Thank you, because you're very echoey.
Okay, let's quickly check. Is it better now?
Yes, and you need to be in the English channel, please.
I am.
Thank you very much, sir. Continue, please.
All right, thanks a lot. So I'll restart again. So good morning, everyone. My name is Benoit Archambault from Health Canada. As usual, I'm accompanied with Professor Charles Perry from South Africa. So Charles, I think you're online. I can see you. So good morning, everyone. Good agenda today for the December meeting of the subcommittee 2.1. We have 2 presentations. Actually, we have 2 instead of 3 as we used to have in the last few meetings, so that will provide us a little bit more time for discussion, questions, and remarks. So we ask you, if possible, at the end of the conference to ask your question and provide your comments in order to get things moving. So we'll start with the first presentation from Hernan Epstein, a statistician at the UNODC, so United Nations of Drug and Crime Research and Analysis Branch. So Hernan will present on the topic of the annual report questionnaire. So Hernan, I hope you're there. The floor is yours.
Thank you very much, Benoit. Good morning, good afternoon, everyone. Let me see if I can now share my screen. Let's see. Can you now see my screen?
We can see that you're sharing your screen, and now we see your slides. You may want to bring your slides into the slideshow mode, please.
Is that in slideshow?
That's now in the slideshow. Please go ahead.
Perfect. Thank you. Again, as Benoit said, I'm a statistician at UNODC. I work specifically in the statistics section here in Vienna, and we work on many data collections. One of them is the annual report questionnaire, which is one of the main global data collections on drug issues. This presentation, I will talk about a bit about the ARQ, the challenges that we have, but it's also an idea to, the main reason for the presentation is also to explore potential initiatives that can help, in this sense, improve the production of data at the national level and improve the reporting at the international level to have a more complete picture of the drug world problem. So what is the ARQ first? The ARQ is an annual mandated data collection which gathers annual aggregate data and information on a wide range of subjects related to drugs. ARQ stands for the Annual Report Questionnaire. I will touch upon later on what specifically is collected from this, but member states are mandated to report to UNODC on this via the 3 international conventions, the 61, 71, and 88 drug international conventions. This data collection, the ARQ, has been around for over 30 years, so there is a wealth of information that has been collected with long time series as well. And recently in 2021, there was a review which actually started in 2018, so it took about 3 years, that included input from member states, from international organizations, and that ended up with a new ARQ and also a new platform for countries to report on. Before, countries used to report data via Excel questionnaires. Now they do it via this DXP, data exchange platform, which is a web-based platform for member states. And in addition, there are also, this is just one of several reporting commitments that member states have at the international or regional level. There are other ones, of course, as well. Some examples you can see on the screen. EMCDDA have their own data collection as well. The OAS also collect data periodically. African Union have also their own questionnaire. The ECOWAS, the West African Commission as well, has their own questionnaire. So many countries face multiple commitments in this sense. Back to the ARQ. How is this revised ARQ organized? There are 15 annual modules. You can see now on the screen the different subjects for each of these 15 annual modules that are collected every year. You can see some in demand, prevalence, registries, treatment, mortality. Some on the supply side, seizures, laboratories, etc. And some that are more cross-cutting or covering different issues, such as drug-related crime, NPS, substances, and so on. In addition to these 15 annual modules that are collected every year, there are also rotating modules that are collected every and every 2, 3, or 5 years, so they're not collected every year. You can see now on the screen which ones these are. Every year, in addition to the 15 annual modules, there are between 4 and 6 additional rotating modules that are also collected. And it's important to know that the ARQ collects data that are quantitative and qualitative as well. So countries that don't have necessarily quantitative data, that don't have hard data, can also provide information and insights on what's happening in their country through qualitative questions as well. So all countries can provide data on the ARQ and provide information on the ARQ. A bit about the geographical coverage of the questionnaire. In blue, you can see the countries that have reported to the ARQ in 2022, which is the last complete cycle of data collection. In 2022, there were 125 countries globally that that submitted the ARQ. This is a record. It had never been this high before. And it's also a 14% increase with respect to the previous year, where 110 countries had reported. So this is a great improvement, and it helps provide a more complete picture on what the situation is globally. However, there are still some data gaps that are still present, especially in some specific regions, and some to mention are Central and Eastern Africa, as you can see on the map, the Pacific as well, the Caribbean, and some parts of Asia as well. And I think it's also important to think about why data are reported or not reported in certain countries and certain regions. So first question that we can ask ourselves is whether the data are actually produced at the national level. Are data produced at the national level? If they are not, then these data, of course, are not going to be reported internationally. We call this one case of why these data cannot be reported, and we call it that there's no data. We say that there's no data production in this case. Potential reasons for this could be a lack of capacity or resources in certain countries for indicators that can be quite complex, technically speaking, or also sometimes lack of centralized systems because there's no way to pool all the data together that is necessary to produce certain indicators. But there are also cases where data are actually produced at the national level, but they're not reported internationally. So if then we ask ourselves, for those indicators that are actually produced at the national level, are they reported at the international level? If yes, then the data will, of course, become available. But in some cases, they are not reported. What could be potential reasons for this? It could be that there's a high response burden on member states, and they cannot reply to all the commitments that there are in terms of data reporting. It can be that there's a lack of coordination of centralized systems. So, for example, that not the right persons or the right agencies within the country are involved in the data collection. And it can also mean that there's no capacity or there's limited capacity to report, in the sense that it's difficult to provide the data on the platform itself, and countries don't understand how to do this. This can also happen. This we call no data reporting. So there are two main reasons for which there could be unavailability of data: no data production and no data reporting. How to treat these and how to potentially address these are different. It's different, and it can be different cases that we can think about. So, for example, let's take a look first at the no data production case. And here you see an example. These are often indicators that can be complex or even expensive to produce, or maybe that the data is not pulled properly from the different sources that is necessarily to be pulled from. You can see here an example of the response rate for countries that actually submit the ARQ on different indicators on demand. You can see that annual prevalence shows much lower reporting rate than the other two indicators. And this is very likely because annual prevalence is a very expensive indicator to produce because it requires a survey at the national level. Then drug-related deaths, and then people in treatment is the most commonly indicator reported, and this is because it comes maybe from sources that are more easily available, such as administrative data. Here on this table, you can see some potential solutions, some examples of how we could address the issue of no data production. And also on the right, you can see some UNODC initiatives that are either already in place or have been in place, and that could help also address these issues. And the way to do this is mostly through capacity building at the national level and through providing materials and guidelines on how to produce these type of indicators. Some examples on potential solutions will be manual on drug use surveys, which is something that UNODC is currently developing. Guidelines for wastewater analysis. This is something was mentioned in the November meeting, I believe. Methodological guidelines also for complex estimates and so on. Also, capacity building, as I mentioned, is important. Regional and national network workshops could be very helpful for countries to learn on how to produce and how to compile these type of indicators. Technical support to countries on specific statistical exercises, such as surveys, and the implementation of the manual on drug use surveys, which was mentioned before, potentially through piloting, for example. UNODC also has been doing some of these types of workshops that I mentioned, either at the national level or regional level, and it has also been supporting the implementation of drug use surveys in certain countries, for example, Nigeria and Pakistan. Now, to address the issue of no data reporting, this is an easier issue in a sense, is an easier issue to address because it doesn't require such big efforts in terms of building capacity at the national level. Again, here you can see some potential solutions to how to address the issue of no data reporting. And I think on this, coordination amongst international organizations could be an important initiative. A potential solution could be to streamline regional and international data collections to decrease response burden on member states. Like I mentioned before, many countries have maybe 2, 3, or 4 reporting commitments, and this is maybe too much for them. So a way to share the data and to streamline these data reporting initiatives could be a way forward. On this, UNODC has already been in contact with some regional organizations such as the African Union, OAS, to see how this could be potentially implemented. And also, capacity building and support on international data reporting could be an important tool as well, because as I mentioned before, on the ARQ, maybe sometimes countries may be lost as to how to report, how to provide the data directly on the DXP platform, the platform that I mentioned before. On this, from UNODC, we do regional and global workshops at the regional level and globally, like I mentioned. Some are virtual. We do this every year. Every year we do a virtual regional workshops, about 5 a year. But these don't have the same impact as the in-person ones that we do. So we've had also a few experiences doing in-person regional workshops with countries on inputting the data into the ARQ and helping them, support them in providing the data. This was a specific ad hoc initiative for West Africa, for example, where we had additional, there was some funding available to do this. So we were able to do this both in 2022 and in 2023. And you can clearly see here the change in response. You can see in 2021, we did not do this in-person workshop, and you can see there's a much lower response rate in West Africa than in 2022, where we actually did it. And in 2023, we did it again, and you can see again a very similar response rate to what is shown here in 2022. So this is my intervention. Again, the main goal of this intervention is mostly to have a few suggestions of what initiatives could help populate the data ecosystem at the global level on drugs and on synthetic drugs specifically. And I hope this can also motivate more further discussion. Thank you very much, Benoit.
Thanks very much. It's Charles Perry here from Cape Town. Good morning, good afternoon to you all. Thank you. We're going to hold off questions, Hernan, until after the next presentation, but thank you. That was very, very clear. So we've got now a presentation on building capacity of health and social services to deliver screening and brief interventions and referral using the World Health Organization Assist Technical Package. And I've got Dr. Goodman Sibeko from the University of Cape Town, Department of Psychiatry and Mental Health. And I don't know if Dmitry Krupchanka from Dr. Krupchanka from the WHO is with us, but he's also listed as a person on this presentation. Are you there, Dmitry? Will you also be presenting?
Dmitry was unable to join us today, but we do have a recording queued up that will follow Dr. Sibeko's presentation. Thank you, Charles.
Thanks, Sarah. Okay, Goodman, over to you, please.
Thank you, Charles, and good morning, good evening, good day to everyone. Can I just confirm that the screen is appropriately visible?
Oh, good.
Goodman,
Thanks, Goodman.
It is visible, but if you could speak a little bit closer to the microphone, please. You're a little bit distant. Thank you.
Yeah, let me see. Is it any better now?
Please go ahead.
All right. So if you struggle, just let me know, and I can just swap out my mic because I think it might be using my camera mic. So I'm just going to talk about the Web Assist, and I think that Dimitri's contribution was just to contextualize where this fits within the greater WHO package. So from my side, so the challenges we sought to address in developing the web app version of the WHO Assist is that in South Africa, as Charles will tell you, there's no current comprehensive epidemiological data for mental health and substance use. There's no comprehensive risk map for substance use in South Africa. And I think this is something that's matched in other sites across the world as well. So we don't have a living, breathing idea of what the risk data is on the ground because we don't have mechanisms to pick that up. And of course, we all know there's limited funding and human resources to immediately address these needs. Current strategies, certainly locally, include limited indicators on our health platforms. And of course, Sekendo, which reports largely the treatment demand data. So it only picks up folks who come to get help. It doesn't pick up people in the community who might need help, but haven't come in yet to access that help. So why have we gone with the Assist? Again, I think this is preaching to the converted. You'll all be aware that the WHO Assist asks about recent substance use over the past 3 months and also looks at lifetime use. It's a comprehensive list of substances, which includes tobacco, which is often overlooked in screening tools, and alcohol, providing a level of risk for each substance. And then importantly for our context, providing a brief intervention component, which provides feedback covering physical, medical, psychological risks. This is important in our context because we have a limit in terms of treatment service availability. Many stakeholders have said to us, part of the reason they're resistant to screening is because they don't feel that they have then the services available to meet the demand created. So what we're saying to them is the value of doing an expert intervention, such as something to assist, is that you're able to provide some assistance along the way, so that you might discover some people don't actually need that onward referral when they have that early contact with the brief intervention. And having said which, only 5% of folks who get screened actually are detected to be at high risk and in need of further assessment and intervention. To backtrack a little bit, why did we develop the Web App Assist? The National Department of Corrections came to us and said, we've got all these seizures, so we know which substances are coming out of corrections, but we don't know how this matches with how people within the correction system are actually engaging with substances. So they wanted to have an idea of what the risk or the patterns of use within the Department of Corrections are, but then to use this as a capacity building mechanism to capacitate Department of Corrections staff in screening and brief intervention. And so we then went through this
And
process.
Goodman, I'm terribly sorry for interrupting. Interpreters are struggling with this audio because it's still a little bit echoey and distant. Can we try the other microphone that you have?
Sure, let me do that.
Thank you so much. Apologies to everyone.
No problem. Let me just do this. That is so strange. So what is the sound like now?
Well, it's about the same, I would say. Can you talk to me a little bit longer?
What about now? What is the sound like now? Okay, let me try this. Let me try moving. Is that
Talk to me again, please.
any better?
I think the previous one was a little bit better. It was less echoey,
Oh, okay. So I'm
even
not
though
sure
it was a
what's
little bit soft.
I'm not sure what's causing this. So is it still the case now?
Right, yes, you're a little bit too far from the microphone. If you could move closer to the microphone, that would definitely help.
I promise you, I could not get any closer to the mic unless I jumped into the MacBook myself.
Right, okay. Thank you very much. Interpretation team, I apologize. And Goodman, please go ahead.
Let me try this. How's that? Is that any better?
That's a little bit better. Thank you.
Perfect. So that it helps having 3 mics as opposed to 2. All right, let me try and continue. So apologies for that. So what we then did with Department of Corrections is we sought to capacitate their management team to provide training in screening, brief intervention, and referral to treatment using the ASSIST tool, because we figured this would be a way for them to not only detect risk levels within corrections, but also create capacity for brief intervention. So we used the paper version of the ASSIST. And what happened there is, as you could imagine, areas that had challenges getting their forms into the center lagged behind in terms of getting data in. There were several human factor errors, such as at the data capturing point. We then had to get the data in and analyzed by somebody at UCT. So that all took a lot of time. And so all
Goodman,
these.
I'm terribly sorry one more time. I'm sorry. I promise it's going to be the last interruption. We are having audio issues because you are not in the English channel. If you can click the icon of the globe, please, and switch to the English channel and continue. Thank you.
Oh, is that what's happening?
Maybe that's why you are having that audio. So you need to click the icon of the globe, please, and be in the English channel, because if you are not on the interpretation channels, we're getting audio mix and people cannot hear the interpretation. Thank you so much. Please continue. Thank you.
How's that going now?
That's much better. Thank you.
All right. Well, Charles, this is eventful. Let me end my show and start it again. And so, all right, is it better? I hope that's better.
It is better. Thank you.
Okay, thank you. And so for all of these logistical reasons, we then developed the Web App Assist to continue rolling out assist provision within Department of Corrections at the end of last year. So in terms of the Web App Assist itself, this QR code leads to the landing page of the Web App Assist. It is anonymized, so it doesn't collect any identifying data. And so this can be modified for specific purposes, and I'll speak to what that means in a moment. With each instance of screening, a random code is generated. Can be used on any device, it's data light, and the automation reduces training and supervision burden. And at the end, I'll show a screenshot of this as well. A screening report and intervention recommendation is provided, which can then either be screenshot or emailed, following which the email entered for receipt is not stored on the system. So just a note to say this was developed through funding from US Department of State. It is hosted and maintained by University of Cape Town and supported by WHO. So these QR codes, the first one leads to the landing screen for the assist tool. The second one is for the practitioners. So if you go to the main landing screen, you'll be able to see that you can access this as either for self-screening or for practitioners who want to screen providers within their practice. So this screen sort of indicates what the pathways are that we've designed into the tool. So there's a pathway for self-screening where members of the public, such as yourself and myself, can go. This really, the benefit is about self-administering the tool, really pushing self-efficacy and ownership. And I've just had a drawdown of the data from the Assist tool. Actually, we've discovered almost 752 of the 1,200 screens that have taken place so far have been self-screened. So this is very encouraging for us. Part of the methods that have been suggested by some of the policymaker stakeholders in South Africa is that self-screening kiosks are placed throughout the health primary care settings in South Africa so that clients can self-screen before they go to the GP, who can then look at that score and then provide additional support as required. We then also have the practitioner screening pathway, which we ask practitioners to log on and create a profile so that they can keep a record of all the screens that they've undertaken. The usefulness of this is that if a practitioner does a screening in another province 3 months down the line, and the client has had another web app screening previously, that we can reliably compare these data, these risk profile data. In terms of special projects, so these can be research projects. We've had a master's project run with medical students at University of Cape Town already. There's a couple of more underway. And there's also a special project under Department of Corrections. So the requirements of the special projects can vary, and there may be special projects such as with the medical aid funders. I just came out of a meeting with the medical aid funders in South Africa, looking at how to integrate the Assist as part of their outcome monitoring and how they disperse funding and monitor. So there's a lot of utility for this tool, which can be adapted on a use-by-use basis. So on the, sorry. Oh, that's an error. So on the landing page, one is asked to enter the date of birth. And the reason that we ask for this is because we've developed all versions of the tool. So there's the adult and the child and adolescent version. Now the argument might be that the Assist-Y hasn't been completely validated, but that actually presents an opportunity for us to undertake some of that work. And that's part of what we are offering as a value proposition here, as an opportunity to collaborate on that kind of work. Some of the demographics page, as I mentioned, it's de-identified, but these are just some standard demographic data to enable us to really understand and make comment about the data. This is per the standard WHO Assist, so it's just all of the substances. Of course, when you select the substances that are relevant for the client, the others fall away, as you see in this mock case that we've created. And here you see that in our mock case, we had this client having high risk for alcohol, and then moderate risk for cannabis and amphetamine. If one then clicks view report, the report comes out again per exactly the standard WHO. And what is encouraging is WHO has said they are looking at upgrading some of their brief intervention recommendations. And because this is a web app and doesn't need necessarily to be downloaded and updated, it can be updated in the background. We look forward to updating some of these recommendations accordingly. And then one then enters one's email address if one wants to export the report, and this is how it appears in the email that arrives. There are alternative drawdown options that are possible with some of our partners in the funding sector, as well as in the special project side of our projects. We are looking at automatic data drawdowns as well. Where can this tool be placed? In terms of self-screen, our National Department of Social Development has used this at their public health engagements where they have the QR codes up, which might actually explain why we have so many self-screening scores that have taken place. Can be used in social media campaigns, in healthcare waiting areas that I discussed earlier. For practitioners, a QR code can be in their waiting room or as part of their training and SOPs, as well as strategically placed across facilities and healthcare units. In terms of where we are, the tool is fully developed and has been tested for integration. It was launched by the executive on the 29th of May at the University of Cape Town. We've already started disseminating through Secendo. We had our first report through the Secendo platform in October this year. So we're excited for the next update. And the key for us is to link it through to government priority programs and of course global priority programs such as this global coalition. The next step for our side locally is integration with government information system and linking with the geolocated substance resource directory, which we'll be launching in a couple of weeks for South Africa. and of course, localizing content and sort of building out that brief intervention to update it. And of course, as a resource for global coalitions as a facilitation of broad use outside of the country. So sorry for all the hitches with the sound. I hope that sort of still made sense in spite of that. So with that, thanks, Charles, back to you.
Thank you, Goodman, for that. Yeah, I think it's a useful tool that could provide data in countries where, you know, there are gaps in, for example, if you're looking at the, you know, both at national level, it's useful, but also could feed into strengthening the ARQ, which was Hernan's presentation. But let's see, is there, if we can go on to Dimitri's, I don't know how long it is, but then we also want to have time for discussion. So we won't take discussion now, but thanks, Goodman. Will someone be loading Dimitri's, or should we just carry on?
Good morning, good afternoon, good night, good evening, dear colleagues, and greetings from Geneva. My name is Dmitry Krovchanko from WHO Headquarters, Alcohol, Drugs, and Addictive Behaviors Unit. And I would like to make a very short presentation about WHO package, assist package for screening brief intervention that we have in our program developed and used for many years. But just to start with, I would like to highlight what is written in the international standard for the treatment of drug use disorders, that screening and brief interventions, they play essential role in providing support to people with drug use disorders, especially at the level of non-specialized care, helping to detect identified cases, refer further to treatment, or providing brief intervention and guiding, helping people with self-care. So just to say that brief intervention is indeed an essential component for a health system focusing on identification, detection of cases. And in WHO for more than a decade, we have alcohol, smoking, and substance involvement screening test. You have probably heard of it, and you will have it mentioned in other presentations today. So it was developed, as I said, like about 10 years ago to assist primary healthcare workers in conducting simple brief interventions. But also this tool, the guide, goes into detail, providing theoretical basis for SBIs, providing evidence for their effectiveness, and then going into details on how to use assist, how to facilitate asking questions about drug use, and also provide some recommendation on incorporating screening in routine practice. But what is most important, probably this is the main slide of my presentation, is not to forget that assist is not only a screening tool, that there is also a package for brief interventions that is linked to assist. So if somebody does assist with a client, they can further take another guide and provide brief intervention. And also there is another tool for self-help strategies for cutting down and stopping substance use, which might be useful in case if clinician, somebody doesn't have time to provide full brief intervention, they can still give guidance or helpful leaflets that will help people who use drugs to better manage and potentially improve their self-care. And then finally, this is my final slide. I would like to update you that this year we have updated the MBChB recommendations, and one of the recommendations that was updated was exactly on brief psychosocial intervention, especially for people using cannabis or stimulants, including also synthetic cannabis as stimulant. And the big change from the previous version is that the strength recommendation is not anymore conditional. So this is a rare example where we have a strong recommendation that people should be provided with screening and brief intervention. And if they're dependent, that they should have a referral for specialized treatment. But for these purposes, we have other tools such as MBChB, international standard, and other guidance. So I hope that you find this short presentation useful, and if you're interested, we would be happy to provide technical support on implementing, scaling up. screening and brief intervention for people using drugs, including synthetic drugs. Thank you for your attention.